Hi, I'm Dr. Joe Niamtu, face.com, and thank you for following our channel. You know that facelift surgery is absolutely one of my favorite procedures, but today we're going to talk about cosmetic eyelid surgery, or blepharoplasty, cosmetic blepharoplasty. Bleph refers to the eyelids. And again, this is something that I just love doing. It makes me want to come about some of the myths, what I feel is the right way and the wrong way. And one of the big things, if you look at doctors that do a lot of eyelid surgery, and I've done almost 6,000 eyelids over the last 20 years, you'll notice that these people are pretty artistic, because this is one of these surgeries that is an art and a science. So yes, there's science there. You have to know the anatomy. I mean, it's the eye. You have to know how much skin to take away, and it's very important to know how much skin to leave. That's almost more important. And everybody, in terms of the amount of skin or the amount of fat, and very frequently their right lid is different from their left lid. So again, it's an art and science. Now, where you have problems when you are doing eyelid surgery is if there's bleeding. And these could be serious problems that could even lead to blindness in very rare circumstances. So blood is not a friend in blepharoplasty surgery. And this is why I use the CO2 laser. And I'm going to show you some videos, and we're going to have another little presentation after I'm done talking here. And you will see using the CO2 laser makes a bloodless surgical procedure. I literally don't lose 1 drop of blood or 2 drops of blood. You could measure the blood loss from 4 eyelids, both uppers and both lowers, on a Q-tip. And this is huge, because if you bleed, especially if you bleed behind the eye, you can have a hematoma, a retrobulbar hematoma, which is a serious emergent medical condition. But above and beyond that, because that's rare, increased bleeding causes increased bruising, it causes increased swelling, it causes increased pain, and it lengthens the recovery. So with the laser, we can do 4 eyes in less than an hour. And I also use dissolvable stitches, because we see a lot of patients from out of town and they don't have to have their sutures removed. Now, upper eyelids are pretty straightforward. Experienced surgeons can measure the skin and know how much to take off, and it's very important that you measure the patient's eyelid crease, and sometimes we'll adjust the crease, but both creases have to be 100% equal, and then we can decide how much skin to take off, and that's pretty straightforward part of blepharoplasty. Again, I do this with the laser. I take off some skin, I take off a little strip of muscle to define and have a really nice defined aesthetic crease after the surgery. And if there's extra fat, we will remove a little bit of fat. Now, lower eyelids, this is a whole different situation, and here's where a lot of people get in trouble. So for years, many surgeons, and some still do, and by the way, this is not a reflection on how other doctors do it. I'm going to tell you how I do it, what's kept me out of trouble and given me safe, predictable results. But some doctors will make an incision externally under the eyelashes and carry it out this way. And when they do that, they're separating the skin and the muscle. They'll take out some fat, and they're going through a structure called the orbital septum. And when you approach the fat from the outside, you go through that septum. And I'll show you some pictures in the little lecture I'm going to give. And that septum can contract. And the other problem with this approach, which is called a external subciliary approach, is that you're cutting skin away. And when you're cutting skin away, you see people that have their eyelids pulled down and you can see the white of their eye. And that's a big problem, okay? And that's called lower eyelid malposition. So lower lid malposition is not a good thing. It can be a big problem for patients, number one, because their eyelids are pulled down and they're not supposed to be. Number two, it can cause dry eyes, and that can be a big problem for patients. So how your lower lids are done, what method, it can be extremely important. Now, I use what is called transconjunctival approach, and I'm going to show you pictures of this. And what we're doing, we're making our incision with a laser on the inside of the eyelid. So there's no external scar. And this allows us to go behind the septum. So the orbital septum that I said other doctors are cutting through, we're preserving that, and that's not going to contract and pull the lids down. So it's a great way. It's a little bit more technically difficult, and you have to be a little bit more proficient, and there comes that art and science together. But it's an invisible incision, and again, we make that on the inside of the eyelid, and then we can take the fat out. Now, the only thing about this approach, the transconjunctival approach, is it doesn't do anything for the skin. So what do? We laser the skin with the CO2 laser. Now, before, like I told you, a lot of doctors will just cut skin off, okay, to rejuvenate the lower lids. When you cut skin away, you're changing the skin quantity, but you're not changing the skin quality. So you're taking that aged, sun-damaged, oftentimes pigmented skin that's wrinkly, and you're cutting some away and you're stretching it. So you're just stretching the old skin. It might look a little bit better. If you take too much away, again, you got to worry about lower lid malposition or ectropion. So I use the CO2 laser, and what we're doing is we're changing the skin quantity because we're tightening it. The laser tightens it, but we're changing the skin quality. We're burning away the old, aged, pigmented, wrinkled skin, and new skin grows back, and new collagen. And so we have changed the quantity and the quality. We're making entirely new skin. Also, there's much, much less chance of lower lid malposition or ectropion. So the recovery for eyelid surgery is roughly a week. Now, that's not a week before your class reunion. You know, I think it works great when a patient maybe does it on a Thursday or Friday. They have a weekend to recover. They have a full week that they stay out of work, and then they have another weekend. So that's about a 10-day period. On the upper lids, you really don't see the incision when the eyes are open. And on the lower lids, the thing that delays the recovery a little bit, at least the way I do it, is the laser, because it's a burn. I would say that patients within 7 or 8 days, but some patients will stay pink for a number of weeks, and they'll have to cover it with makeup. So it's a little longer recovery, but it's a safer procedure for avoiding lower lid malposition, and you're rejuvenating the skin. So the last thing about eyelid surgery, if you go talk to a surgeon about your, and if they don't mention brow position in the first paragraph, you might want to look at another surgeon, because the brow position is very important. And some people do blepharoplasties, but they're not skilled in brow lift procedures. You always have to offer the patient a brow lift if they're a candidate. Now, some patients, and I would look pretty good if I had hair, with a brow lift. And the problem of not diagnosing that, number one, you're shortchanging the patient because they may desire a brow lift, and that may make them look better. And also, if you do a brow lift, you might not even need to do the upper eyelids. The other problem is if you take skin away, a lot of skin, or if somebody has 2 blepharoplasties and then they decide they want a brow lift, there's not enough skin to close the eye, okay? So the preoperative conversation is very important. You have to consider if the patient is a brow lift candidate and offer that. There are so many other factors that go into blepharoplasty surgery for safe surgery. If a patient has hypertension, if they have diabetes, if they've had LASIX in the last 6 months, you have to make sure that they're going to rest for that first week. It's very important because people that have bleeding problems frequently overdo it, especially when you use a laser. They don't bleed, they feel so good, they go home and do stupid things like work in their garden or sheetrock their garage or something. So you need to take it easy. The doctor has a lot to do with the outcome. The patient has a lot to do with the outcome. And so you have to do a visual examination. You have to make sure and document anything changes in the eye like ptosis or droopy eyelids. There's a whole lot that goes into cosmetic blepharoplasty, but it truly is an art and science. And the upper face ages a lot faster than the rest of the face. So whereas we're doing facelift surgery in patients in their 50s and 60s and on up, it's not uncommon that we're doing eyelid surgery on patients even in their late 3rd decade. So they say the eyes are the seat of the soul, and we get puffy, and I'm going to show you the aging changes in the little lecture I'm going to give right after I do this. But the eyes make if the aging eyes, where you have extra skin and fat, they make us look old and they make us look tired. So you can invest less than an hour of your time and roll the clock back a couple decades and look more awake and more alert. There's two things that I have to do to be successful. Number one is safe surgery. We have to have the latest equipment, the latest lasers, which are very expensive but very useful, and the knowledge to do this with a positive outcome. And the second thing is natural results. My patients don't want to look operated. I don't want them to look operated. I want them to look refreshed and alert. So stick around. We're going to do a little lecture here about this. And the art and science of cosmetic blepharoplasty. I'm Dr. Joe Niamtu, LoveThatFace.com.
Hi, I'm Dr. Joe Niamtu, LoveThatFace.com, and we're going to do a little lecture here. Now, this may take a little while. It's probably about 10 minutes, and it might be a little detailed. However, you may only have eyelid surgery once in your life, so it's very important to understand what to do, what not to do, and the safest and most effective ways to have a natural outcome. I have a passion for academics and education, and I teach a cosmetic surgery course at least once a year, and we have doctors from all over the United States and all over the world from all specialties come to learn cosmetic surgery at our surgery center. I also have an online video series for doctors how to do these various cosmetic surgery procedures, including eyelid surgery. And I'm a prolific author. I have two of the top-selling medical textbooks on Amazon right now, the second edition that I'm holding in my left hand of my book, Cosmetic Facial Surgery, and also my newest book, The Art and Science of Facelift Surgery. So I'm passionate about learning, teaching, and operating. This is from our course in September of this year, and again, teaching young doctors is one of my passions. So here is a picture from my last course, and again, we're doing eyelid surgery, so we have magnifying glasses on to help us with that surgery. So I love blepharoplasty surgery. Like I said, I think it is one of the most straightforward and dramatic procedures that you can do on a patient, but really does take decades to become very good at this procedure. Let's talk a little bit about the eyelid skin. It's actually some of the thinnest skin in the body. It's less than 0.2 millimeters thick in some areas. And as we age, we have different situations that occur, such as excess skin and fat that protrudes from behind the eyelids. So we all look in a mirror and pay attention to the amount of skin we have. And if you take your upper eyelid and pinch it like this, and if you have a big crinkle or wrinkle of skin that persists, then you certainly are a candidate for eyelid surgery on the upper. And if you need uppers, you frequently need lowers. So most people are doing all four lids at the same time. So we're going to discuss fat herniation, and this is when the fat protrudes through the deeper structures, and there are actually fat pads that surround the entire eyeball, and these help cushion the eye and protect it. But as we age, these can herniate, and this gives us these bags under the eye. And these, when you have bags under the eye, it creates a shadow, and some people mistake that as dark circles. Now, sometimes it is pigment, but frequently it's just shadow. So again, what happens is we have this fat that sits behind the skin, and the structure that we discussed called the orbital septum is what holds this fat back. And if this becomes weak, then this fat protrudes and gives us the typical aging lower eyelid with fat protrusion and shadows under our eyes. Now, some people have what is called orbicularis hypertrophy, And orbicularis hypertrophy is actually excess muscle, and you see this when you smile. Some surgeons mistake this as fat, so it's very important, obviously, to know the difference between fat and muscle. And you could actually Botox this and improve it, or you can take out a little bit of that muscle. So that's a less common problem, where fat protrusion is much more common. Festoons are kind of waterlogged tissue, uh, a process known as lymphedema, where we get these big bags under the eyelid at the eyelid cheek junction, and these can be very difficult to treat, but CO2 laser resurfacing, as we'll show you later, is a good way to treat this. So heredity plays a big part in eyelid aging, and it's not uncommon for patients really in there. Like I said, I've operated in patients that were under 20 years old that had protruding fat that was just heredity. So our ancestors have a lot to do with how we look and how we age. We're going to talk about some anatomy right now. And our eyelid crease is a variable situation in our upper lid, and this has to do with the fibers of the structures attaching in the upper eyelid. So in a Caucasian female, this is usually about 10 to 12 millimeters where the crease is, and that's the crease that's above your eyelids. In males, it's about 6 to 8 millimeters. In Asians, it's much lower, and it's 0 to 4 millimeters. So again, it's important that the surgeon understands all the nuances of the eyelid and related anatomy. The lacrimal gland in the upper lid, this makes the tears, and this is usually in the lateral part of the orbit. So unfortunately, there have been cases where surgeons that weren't very good at anatomy took out the lacrimal gland, mistaking it for fat, and that would be, of course, catastrophic. So obviously, the anatomy of the orbit is very important, and one must realize the difference between glandular tissue and fat tissue. Now, in the upper lid, there are two fat pads, a medial and central. In the lower lid, there are three fat pads, a medial, central, and lateral. And this is not exactly the same in every patient, but in most people, we have two fat pads on the upper, three on the lower. Now, when you do blepharoplasty surgery, like any type of surgery, there are health concerns. And you remember I said patient safety is our number one thing that we pay attention to. So, has the patient had previous eyelid surgery that may affect the blepharoplasty? Does the patient have thyroid disease? Are they going to have cataract surgery? A lot of questions to be asked. People that have dry eyes, you really have to be careful when you do blepharoplasty surgery on patients that have dry eyes, because you don't want to make their problem worse. Bleeding, as I said, is the major enemy of eyelid surgery. So patients that have a bleeding problem or a platelet problem or on blood thinners or aspirin, they have to come off of this, and you have to have control. Otherwise, you can have problems. We talked about thyroid problems. We talked about uncontrolled high blood pressure, uncontrolled diabetes. Um, a lot of doctors will make their patients wait 4 to 6 months after having LASIK. So your eye health and ophthalmology health is very important before anybody touches you for cosmetic surgery. Now, we have asymmetries all over our body, and our eyelids are also very commonly asymmetric. So you can see that this patient's crease here is very high. Here it is lower because of the extra skin. So it's not uncommon that you're taking a different amount of skin or fat from one eye versus the other eye when you do blepharoplasty surgery. Now, this is an important picture here because this is something that you don't ever want to have happen. And this is called lower eyelid malposition or ectropy, and we talked about this. The major cause of this disability, and it is a disability because these patients, it's a functional disability because it's hard for them to close their eye and they may have dry eyes, and it's a cosmetic disability because it looks bad. You're not supposed to see the white part of the eye. And what the most common cause of this is doctors that do external subciliary approaches where they're making an incision down here on the outside of the lid and cutting away skin. All right. Now that doesn't mean that every doctor that does that procedure is going to have this happen, but it is much more common when you do this external incision with skin excision, and I see this all the time on patients that have just had it done improperly. So that's a problem, lower eyelid malposition. Now, one of the things that we do are various tests to make sure that a patient has an eyelid that is tight enough that is not going to pull down. So when you pull on the lower lid with your finger and pull it down and let it go, within 1 second, it should come back pretty much to the normal position without the patient blinking. On older patients or on patients that have eyelid laxity for whatever reason, if you pull their lid down and it doesn't snap back, that is a problem patient, and that patient is going to need some type of other procedure to tighten their eyelid at the same time. Otherwise, they are at risk for lower lid malposition. Also, you should only be able to distract the lower lid about 7 or 8 millimeters from the eyeball, and if you can pull it further than that, again, that's another sign that the patient may need a tightening procedure. This is a great example of a patient who would be a good blepharoplasty patient. You pull down on her eyelids and let them go, and look what happens. They don't return to normal. So for an inexperienced blepharoplasty surgeon, this is a complication waiting to happen. An experienced surgeon would do a test like this beforehand and understand that if this patient's going to have blepharoplasty, they absolutely need a tightening procedure, and you don't want to be cutting skin off. It's also very important to document the vision because there will be some minor visual changes at first, and this is just swelling. And after doing over 6,000 eyelids, I've never had a patient with a visual change that was permanent after blepharoplasty surgery. However, people pay a lot more attention to their eyelids after they have surgery. So in that initial week or two, there can be some swelling and a little bit of blurriness. Also, the position of the upper lid is very important, and some patients have a droopy upper lid, which is called ptosis, and that is a separate functional procedure that needs an additional procedure. It's really not so much a cosmetic procedure, and it's important to recognize the position of the upper eyelid before doing blepharoplasty. Now, I alluded to this earlier. So here's a patient that came to me for a brow lift consult. And if I raise her brow, that's a pretty good look. That patient would look good with a brow lift. But when I ask her to close her eyes, she can't close her eyes all the way because she has had aggressive skin removal and nobody gave her the option for a brow lift. And this is actually a very unfortunate situation because this patient needed a brow lift or was a candidate for a brow lift, and somebody just took skin away on 2 occasions, and now she can never have a brow lift. So if you go to a surgeon and discuss blepharoplasty, if they don't talk about the brow position or at least discuss it and offer that option, then you may want to get a second opinion because that's very important in the scope of things. Now, the goal of blepharoplasty is to remove extra skin and muscle and fat so we have a nice crisp shelf above the eyelashes, and this is where females place eye makeup. For males, we don't want to feminize the eyelid, and what we're doing is removing skin so males have a lot smaller crease. And again, we're removing skin muscle, and fat, and it's very different in males and females. You don't want to feminize a male patient, and you want to make a female patient have beautiful, crisp, nice eyelid shelf. So when we mark the eyelids, this is the very important part of surgery. Obviously, being able to do the surgery is important, but you have to know what you're leaving and what you're taking away. And in eyelid surgery, it's really more important what you leave behind than what you take away. And it takes about 20 millimeters of skin to close the eyes. So you can't indiscriminately remove skin. Now, when we mark the upper eyelid, what we usually do is start with the patient's existing eyelid crease, and we'll make a mark, and this crease has to be the same on both eyelids. So it's very important. This is one of the most important parts of blepharoplasty surgery, and if it's off even by a millimeter or so, it can be a problem. So what we do is we mark the patient's natural crease, and then we will make marks above that for the upper part of the incision, and we'll pinch the eyelid skin and make sure that the patient can still close their eye. And once we pinch this skin, you should just see the upper eyelashes start to turn up, but the patient should be able to keep their eye closed, and that's how we test for the right amount of skin removal. Now it's important not to make your incision out in this multi-contoured area because it's visible, number one, and it can cause webbing. So that's a kind of a novice beginner's mistake. Now, as I told you, the creases have to be exactly equal on both sides. So that's the lower marking. However, the upper marking is frequently different. So on this patient has 7 millimeters of extra skin here, but 12 millimeters of extra skin on this side. So it is not necessarily the same amount that will be removed, but it is essential to have these lower markings at the same place on both eyes, and it's a game of millimeters. Now, it's very important to protect the eyelids. Patient safety is always our number one concern. So if we're using a laser, which I usually use, we put in a metal contact lens to protect the eye. If we're using electrosurgery or radio wave surgery, such as the Elman, then we'll use a plastic shield. Now, bleeding, as I said, is the major enemy of eyelid surgery. And when you use a scalpel, everybody knows if you cut your finger, it's going to bleed. If you burn your finger, it's not going to bleed. So extra blood means more complications, more pain, more bruising, and longer recovery. When we use the laser to make this incision, there is zero blood. Or if we use radio wave surgery like the Elman radio wave, again, another way to do this bloodlessly. There are a lot of big blood vessels in the eye, and this is why I always wear a headlight and magnifying glasses when I do my surgeries, because it's very important not to cut these blood vessels and have the ability to cauterize them. So here is a upper eyelid laser incision.
Okay. What you notice about this incision is the lack of blood. And I just love the laser for making my blepharoplasty incisions. Okay, stop.
So you can see that that is a bloodless incision. And by the way, I do all of these procedures under sedation in our in-office surgery center. Now, we already mentioned that you have the orbital septum, and then under this layer in the upper lid we have two fat pads. We have the central fat pad and the nasal fat pad, or it's also called the medial fat pad. And we're going to reduce some of this fat if it is necessary. In many patients it usually is necessary to reduce some fat. And this can be done with various instrumentation and using the laser or the radio frequency, but it's so important to do this without bleeding. Now, it's also important, this is not my patient, but this is a patient who had too much fat taken out. This is called an A-frame deformity, like a A-frame on a house. And so it's very important, like I said, not only what you take away, but what you leave behind, because you can make a patient look skeletonized and older if you don't know what you're doing. We always take a little picture of the extra fat, the extra skin, and the extra muscle that we remove just for our patient records. And we use a dissolvable suture when we close this for several reasons. Number one, no one have sutures removed, and frequently removing sutures can tear the incision or stress the incision. And so we use dissolvable stitches that will dissolve in about a week. Also, I see very many out of town, so many out of town patients that it's just easier so they don't have to find somebody to take their stitches out. So we use dissolvable stitches, as I said, and these come out in about a week by themselves. Now, I want to talk about lower lid blepharoplasty, and this is very important. I said earlier that a lot of doctors will do external subciliary incisions. In other words, they'll make an incision under the eyelid, and they will take the fat out, and then they'll cut some of this skin away. Now, not every surgeon that does this is going to have problems, but I can guarantee you, and if you talk to most oculoplastic surgeons, they will tell you that this is a procedure that is more commonly associated with problems of lower eyelid malposition. So I do not do this approach. And when we cut through the orbital septum from the outside, like I said, the septum will contract. This is a picture from my textbook, and it can pull the lid away from the globe. So to me, it's a safe way to do that. And usually when you see people that have this kind of situation after blepharoplasty, they have had that surgical approach. So you got to beware, and you have to discuss this with your surgeon, especially if he or she favors that approach. What I do is the transconjunctival approach, where we're making an incision from the inside of the eyelid, so we are not disturbing this orbital septum. And what we're doing is rolling the eyelid down, and we're making an incision on the inside. So number one, there's no scar. Number two, it's not going to affect the amount of skin on the outside of the eyelid that can pull the eyelid down. We make this incision again with a laser or radio wave surgery. And there are 3 fat pads in the lower in this picture, which is probably going to gross some people out, but today's patients like to see this type of thing. These are the 3 fat pads. So you have the nasal fat pad or the medial, you have the central, and you have the lateral, which is also sometimes called the temporal fat. Now, it's not uncommon to see patients that have had lower eyelid surgery. This is not my patient. Somebody operated on her, but they didn't take out all of the lateral fat pad or enough of it. And that's the most commonly missed fat pad. So the surgeon has to pay attention, make sure that they isolate the extra fat in the 3 fat pads. Otherwise, you're not going to have a cosmetic result. You're going to have a lump.
Skin excess. And we're going to zoom in a little bit here, okay? And we're going to make an incision from the lacrimal carbuncle to the lateral canthus. And the laser is a bloodless instrument, so you see there's no bleeding, and we're going to start to see the fat here protrude. Just wait.
So once we take the fat out from the upper or lower, since I am not cutting skin away, and I've told you why many times, I am either doing a chemical peel, and that's more common on darker skin patients, or I'm doing a laser resurfacing, which is more common on lighter skin patients. Now remember, I told you that people that cut skin away, they're only addressing the quantity of the skin. They're not rejuvenating the skin. But when we do a chemical peel or a laser, we're making new skin. And at first, it looks pretty rough, okay? You would think this is painful, but it really isn't. This is nature's Band-Aid. And what we have done is we burn off the outer layers of the skin, and the new skin is growing back. And usually 7 or 8 days, these patients will be healed and back to makeup. On darker skin patients, we'll do a chemical peel, and then the skin will peel off about a week later. This slide is just to illustrate a canthapexy, which is a tightening procedure. Again, if you have loose lower lids, your cosmetic surgeon needs to be able to diagnose this and treat it properly so you don't have lower eyelid malposition. So the doctor has so many things that he or she has to do for safe and natural surgery, but the patient has a big part in this as well. So what do we want to do after surgery? Well, we want to keep our head elevated. We want to have cold compresses. Cold is really our friend for eyelids. And no activity that is going to increase the blood pressure, so no bending or lifting. You need to really not lift anything over 10 pounds for at least a week. The patients will usually have pain medicine, which they may or may not need, an antibiotic or a steroid. And complications are very rare with eyelid surgery, but you should be able to have availability of your surgeon 24/7. I always tell my patients if they can't call their doctor, then they chose the wrong doctor. And all of my patients get my cell phone and email and that of my staff. So we're going to show you some cases of eyelid rejuvenation. And again, when these patients, this is just one of my favorite things. I love doing this, and I think it's one of the most artistic things that I do. So if you look at the before picture, this patient really in their late 40s, and they have this heavy eyelid skin and wrinkly, crinkly skin on the bottom. And again, we have done upper and lower eyelid surgery and lower lid laser resurfacing, which is my most common procedures. This is the same patient after surgery, and this patient just looks old and tired, and by removing this skin, now we have a nice crisp shelf that the patient can wear makeup if they wish. Same thing over here. Here's another patient, and again, this is a small change, right? This patient her skin was touching her lashes, and after surgery, you can see that she has a nice crisp shelf. Look at the pigmentation and the sun damage and wrinkles that she had, and you can see after lasering the lower lid, the patient does not have that. So almost all of my patients, I'm doing upper lid surgery. I'm doing lower lid on the internal transconjunctival approach like I showed you, and lower lid laser resurfacing. And I just have thousands of before and after pictures. And again, just these little changes make a patient look and feel better. Here's another patient, and this is so common where the skin is actually touching the eyelashes, and these patients aren't able to wear makeup, and they have protruding fat pads, and this is about 90 days after upper eyelid blepharoplasty, lower transconjunctival blepharoplasty, and CO2 laser resurfacing. And these patients always come back with makeup because they haven't been able to wear it. Same patient, looks so much younger just by doing this procedure that takes less than an hour in about a week or so of healing. And if we look at this little motion thing, you can see this patient before and after blepharoplasty. So again, these patients love to come back with makeup because they haven't been able to wear it for so long. So here's another motion graphic that shows the difference before surgery. And again, we have this extra skin. We have our upper lid skin touching the lashes. There's no crease that's visible, and this patient is not able to wear makeup. And we can see after surgery, we've removed this extra skin. We have a very crisp shelf, a nice crease, which in females is about 10 to 12 millimeters. In males, it's a little smaller. Same with Asians. Same patient before and after upper and lower eyelid surgery as I've described. Again, a motion graphic showing a patient before and after. And again, these patients have not been able to wear makeup, so we've taken some skin, muscle, and fat from the upper. From the inside incision, the transconjunctival, we've taken fat out of the lower, and we've done laser resurfacing, and that is my typical eyelid rejuvenation. And these are just other cases. This is upper and lower blepharoplasty. And what we're doing is we're looking at the extra skin, muscle, and fat that we've removed. And not all of these patients come back with makeup. And I try and take my before and after pictures without makeup, but some patients come back on their way to work or whatever. So you can definitely see the difference between the upper and lower lid. Another case, again, and when I look at these, I just really get excited because these are all happy stories where patients just were feeling old and tired, and we've taken some skin and muscle and fat away and done some laser resurfacing, and I think we've really changed their life, and that's why I enjoy this surgery so much. Here's a patient who had festoons, and again, upper and lower eyelid surgery and CO2 laser resurfacing. Another patient, you can see the power of lasering along with eyelid surgery. And again, some of these cases are very simple, but they are dramatic. And males, again, a little bit different. We are not trying to make a big shelf. We're just getting rid of some of the skin and doing upper and lower eyelid surgery. You can see the difference, and it's always a smaller shelf and a lower crease on males. Here's a patient with really significant fat herniation, and when they look up at the ceiling, that is a view that we commonly do that accentuates the fat, so you can see the difference in the before and after pictures. And again, this is my same approach: upper eyelid skin, muscle, and fat; lower eyelid transconjunctival, or the internal approach with CO2 laser skin resurfacing. And I have thousands of before and after pictures on my website, which is lovethatface.com. So males are less dramatic. However, they are in and of themselves dramatic because it makes people look younger and more alert. So again, I really appreciate your time. I know that this is a long video, but I think that you owe it to yourself to invest in the knowledge of understanding the right procedure, understanding a qualified surgeon. And again, we do hundreds of eyelid procedures every year. One of my favorite procedures. You can find out more at my website at lovethatface.com. I'm Dr. Joe Niamtu. Thanks for your time.